So hopefully by now, especially if you've been watching my videos, you are starting to see that there are a lot of things that can happen at end of life, a lot of things that are unexpected that can happen at end of life. One in particular that people sometimes aren't always prepared for is the event of a fall, an incident of a fall. And this is more common than you may think. So we're going to talk about falls today, why they occur, and what we can do to better manage safety at end of life. Hi, I'm Abigail. I'm here to normalize conversations and education about death and dying so we all die better at end of life. Let's get into it today. Even when somebody is bedbound, a fall can happen. So what is a fall? A fall is basically what you know. It's when someone has unintentionally fallen to the floor and it can result in an injury, and sometimes it can be a very minor injury. Sometimes it can be a very serious injury, expediting the time of death. This is not an unusual thing to happen in hospice care. Actually, it's one of the indicators we use sometimes to justify hospice care continuation. If someone, regardless of their diagnoses, is having an increased incidence or starts to have falls, it actually can demonstrate that the terminal stage is continuing to evolve, advance, and death is getting closer, and the prognosis is shortening. The time that they are alive is shortening. This is a normal thing. This is a very expected thing in hospice care that we see very many times, even in palliative care before someone comes onto hospice. Sometimes it's also an indicator that someone needs to start to get on hospice. In addition, this isn't alone. It's not enough to justify hospice care. It's in conjunction with all of the other conditions, diagnoses, etc. So with that said, the one other thing I want to say, because, we really want to talk about how prepared we can be here. We're never 100% prepared for an incident, for the time of death, or anything like that. But it's very important to try to prepare ourselves as much as possible. When a fall happens, whether it's for you or for your loved one, it can feel like an emergent situation. Again, the injuries can be minor, but they can also sometimes be very severe depending on a number of factors. And so when this happens, particularly, if you're already on hospice or your loved one's on hospice, sometimes people just kind of rush and think that they need to call 911. Most of the time when you're on hospice, calling 911 isn't part of the plan of care, especially if your loved one or you is considered a DNR, do not resuscitate, and you're just pursuing comfort measures only. You don't always default to going to the hospital on hospice. Most often what you do is you call hospice and you get assistance there to assess the situation, and it's amazing. The nurse comes out, and if they need help picking you or your loved one off the floor, they can arrange for that to happen. So you have so much at hand and available to you when you work with hospice, as you might have seen in my other videos. But let's get back to falls. So why do we even have falls at end of life? You may be saying, well, my loved one, just got on hospice and I can't imagine them having a fall because, they're in bed all the time. Well, a fall is any time when you make contact with the floor unintentionally. And I should have kind of said that before. So yes, you could be walking and you could fall. You could be transitioning from the bed to a chair and fall. Or you could be in bed and you could roll over from your bed and land on the floor. So all of those are considered falls, just so you know. And sometimes you could be rolling out of bed and someone can catch you and then assist you down to the ground. That is also considered a fall. You're making contact with the floor. Okay? So all those things can happen. Now, why do they happen? Well, for a few reasons. I think probably one of the most common is someone has to go to the bathroom. And it doesn't matter if that person has been in bed for days now. If they have a little rally, if they have a little burst of energy and they feel like they need to go to the bathroom, they might try to attempt to get out of bed. And that could look like them trying to get out of bed, but because they're so weak, they may not be able to stand or sit and sit to stand out of bed. They may do something like rolling out of bed and just kind of rolling onto the floor and hitting the floor. And that's a very, very common thing that I have seen in hospice care. And it's just kind of par for the course in some cases. But the whole point is we need to be prepared for it and we need to maintain safety. Other types of reasons for falls, it could be things like discomfort, like someone is developing some pain. Maybe it's discomfort from a full bladder. Again, they need, some relief in going to the bathroom. It could be discomfort from constipation or diarrhea, or it could be just pain in general. They could be feeling anxious and feel like they need to go somewhere. They could be confused, having some anxiety, maybe having some hallucinations. And so then they're feeling like, I gotta go somewhere. And maybe they're attempting to get out of bed, and that is resulting in a fall, whether it's rolling out of bed or sitting and standing up and then actually falling to the floor. Their environment as well can cause a fall. So whenever we, particularly end of life, I always try to say, remember, we're dealing with a dying body. The dying body is not going to recover as well. It's not going to understand everything. You're going to have issues with breakdown, with organ failure, things like that. So the person will be more confused. The person won't understand what's going on. If there are any shifts in the environment, or if that person has recently moved to a different room, whether it was in the house or maybe they moved into a facility from home or vice versa, that environment is new, and that can add some confusion, and that can cause them to try to make it back to their bedroom that they think they may be going to or trying to get to, things like that. They could just be having anxiety in general, especially if they're having shortness of breath and they don't really realize it's a breathing issue. You're going to be anxious if you can't breathe. So they may think they need to get up and try to get some help, or get up to go somewhere, get something, do something. All very, very common. There are a number of types of different scales that tell us, who's at high risk for falling. They typically look at things like the types of medication someone's on, the conditions from which they have been diagnosed, other types of circumstantial type of things that could cause someone to, be at higher risk for falls. So how do we actually work with this? Like, what do we actually do to try to minimize things? So obviously, when you are on hospice, you really want to work with your hospice team. And if your patient or a loved one or yourself, if you or they are in a skilled facility or other facility, you want to work with the staff there on how to maintain safety. Because when we maintain safety, that is really, bottom line, one of the essential aspects that we need to maintain and, at end of life, or at any time in their life in general, right? So what you can do, one of the things I found most helpful that you can do, is developing a toileting schedule. And I know that seems kind of obvious, and I mean really being diligent about it, even throughout the night. I like to always, when I was gathering information, working with my staff on trying to manage safety, especially for a patient who was having a lot of repetitive falls, was looking at, let's document, when were they actually falling? What time of day were they falling? Most of the time, when we looked at this, it was usually in these wee morning hours, usually anywhere from 2 a.m. to 5 a.m. in the morning. And depending on when they fell asleep, they're usually asleep for anywhere from 4 to 6 hours already. And so usually that would mean, it's time for them to go to the bathroom. So what I would do is, for the nursing staff, or, for the people taking care of their loved one, it may mean, waking up at a certain time in those hours that the person was usually getting up, waking up maybe a little tad bit before then, and getting that person to go to the bathroom. Now, they may not be as strong to walk to the bathroom. You can get a bedside commode from your hospice care and have it at the bedside, or use a bedpan even, and try to help them to go to the bathroom, relieve themselves then and there, so that we hopefully avoid a fall. And I want to take a pause here. That even though you do these things, and you could be doing everything right, whether you're a staff, clinician, or a loved one, caregiver, whatever that may be, you could be doing everything right, and you can still have an unexpected fall. So I for what it's worth, I'm giving you permission to know that that can still happen despite doing everything by the book, despite all your efforts. It can still happen, because unexpected things happen at end of life. It's just the way it is. This is what we need to be prepared for. It happens, okay? So you're not doing anything wrong, and you're not failing your loved one. Please know that. Another thing you can do is, and then, make sure that throughout the day you have regular toileting. During the day, it's obviously much easier than having to wake up at night, right? It's a lot for caregivers just in general, particularly ones at home that are also working, have family members. It is unbelievably hard and can be overwhelming to take care of a loved one. And it's one of my many topics to cover on this channel. Another thing is to really look at schedule of medications, particularly, sometimes you might hear someone refer to certain medications like sleepers. So these are those medications that help someone go to sleep. Make sure you're doing it at the same time every day, and that you're toileting, hopefully, that whatever number of hours afterwards that the person usually gets up. You really want to make sure, especially if someone is dealing with anxiety, if they're starting to get anxious, in certain parts of the day, that you're not getting them to sleep too early. You're not having them sleep too much during the day. You really want them to sleep at night. Sundowning is a syndrome that you can usually run into. It's usually something that happens later in the day during around sunset, and it's usually caused by things like maybe a little low blood sugar, maybe they need to go to the bathroom. So there is a video on that. But that basically what you want to do is you want to give them maybe a little snack if they're really anxious in the afternoon, because it could be quite a bit of time between lunch and dinner. And bear in mind, people who are dying don't usually eat enough or eat a lot. So even though they're having their meals in the afternoon, especially when they start to get anxious, their blood sugar could just start dipping a little bit. So having a little bit of a snack, going to the bathroom can sometimes really help with that anxiety. And trying those before maybe you give them something that could cause them to sleep and mess with their sleep schedule could often work. Now, again, obviously always defer to your physician orders and recommendations, things like that. These are some basic things to help. So a little snack, watching with your medication scheduling, all of those types of things. The other thing too, and this is really more for especially people who have dementia or any kind of cognitive diagnoses, you really need to look at their environment. You need to help that person adjust to the environment as much as possible. So especially if they recently moved into a facility, you really need to kind of help reorient them. You always really want to try to support them as much as possible. You really want to try to, as much as possible, make the room as similar as possible to how their room was that they know in their home. Try to have the table kind of, on the right side that they usually have it on, if it's wherever it is. Have the blanket that was usually on their bed. Maybe if you can, I know a lot of these places, if you're in a facility, sometimes they wear hospital gowns. See if you can allow them to wear a t-shirt, something that smells like them. And have, if they had pictures or certain little things, around their room, if you could have something similar to that or bring it in from home. You can't make it look exactly like the room. I get it. You're working with the facility and their limitations, or not limitations, but their rules, and what you have available to you in the room. And try to make it as, familiar to them as possible. For people with dementia, this is a little bit more, takes a little bit more discovery. So under my dementia series, you can see more about how to work with that. So the last thing I want to say, though, is, if the person, this sounds obvious, but I can't tell you how often this is just forgotten. If the person uses hearing aids, uses glasses, make sure they have those available to them, and make sure that, if they're sitting in bed during the day, or in their wheelchair, make sure that their glasses are on, their hearing aids are working, and, in their ears. These type of sensory type of tools are required to help someone feel a little bit more orientated to their environment. Okay. So this is all kind of very simple things. There are other things you can do, depending on the facility. Sometimes they do allow things like side rails, but side rails, we're getting away from that more and more because there have been more injuries associated with them than not. Side rails now, they might keep them for seizures, and they pad the side rails for safety, but usually they don't. So usually what they may do, especially in a facility, and what that you can also do at home, is have a bed that goes all the way to the ground. Remove the side rails, because you can get your limb or head even stuck in side rails sometimes. And remove the side rails, have the bed low to the ground, and then put mattresses on both sides. And so then what happens is if someone rolls out of bed, if they're really weak and they try to get up out of bed, they just literally roll onto a padded mattress. And then, sometimes you just come into the room and they're basically look like they're sleeping on the padded mattress, and they're quite comfortable. So this is something that you really want to work on with your hospice team to really ensure the safety. Now, the injuries that can happen with falls, like I said, it can be nothing. A lot of times, it's a bruise, and people on hospice, they bruise easily. Again, we're dealing with a dying body. right? So things can happen. Some of the more serious types of injuries that can happen are things like hip fractures, or, they can hit their head and they can have an internal bleed or blood can be coming out. The head is, and you'll see a lot of times, if you're reporting a fall or calling hospital with a fall, they may come and they may ask like if the head has been hit. One of the layers in the brain that is very fragile as we get older and as we become, more ill, is this epidural layer. And if there is a bleed in that epidural layer, it's actually quite serious in that it can hasten death sometimes. That type of injury, causes a lot of bleeding, and, usually prognosis after that, in terms of, how long a person has to live, is usually shortened. And again, you could be doing everything right. Everything could be perfect by the book, done by the hospice team, done by you, the caregiver, whatever. But these things can still happen. So falls, sometimes when they happen, they just seem like such a shock. And then all of a sudden they think, the person's dying all of a sudden. And then, thinking, oh my God, I just totally caused my mom's death. You didn't. Some of these things happen out of the blue, and this is why we talk about it, because even though, again, someone who has been in bed even for weeks, days, maybe even months, can have a fall. They may try to get out of bed and have a fall, especially at end of life if they start to develop terminal agitation. They might have been in bed for days, weeks, whatever, and then all of a sudden they start to develop this state of agitation that happens in the very terminal, the very end stage, right before they die. And they can, they rally up a little amount of energy and they may try to get out of bed and they can fall and hurt themselves. So know this is not your fault. Know that these are expected, things that can happen, and all those things are very normal, but we still always want to do the assessment. In hospice, when they admit somebody to hospice, they do a safety assessment, and part of that safety assessment is to assess the risk of fall, whether someone, and deem someone based on the medical assessment if they're low, moderate, or high risk, and set the appropriate interventions in place to maintain that safety and work with you on that. Let me know if you have questions. I know that there's always a lot of stuff that we cover here, and there's just so much that can happen at end of life. This is certainly one of the things that can happen and can happen unexpectedly. So by all means, if you have any questions at all or need any clarification, please always put them in the comments. I will read every single one and answer every single one. I really appreciate you always joining. I just want to make sure that this is always helpful to you. So let me know, how I can make this more helpful to you. And if you have other questions or want some other topics covered, we're going to be covering a lot. We have a lot to review and cover. This is a big subject. So I plan to get all of this covered sometime during my life. All right. I'll talk to you soon.